Welcome to this video on professionalism. This is aimed at the undergraduate students in family medicine at RCSI Perdana and Professor Anthony Cummins. Before we go through the video, let me just show you a piece of current news from the Irish courts concerning an alleged case of malpractice. This concerns the parents of a baby boy who died within 17 hours of birth. They felt they weren't listened to. Whether there was medical negligence or not is for the courts to decide, but two things that emerged from this were, one, that in the brief time that he was alive, this lady was unable to cuddle her baby Connor, and this is what made her very angry and very sad. The second issue was that the day after the baby had died, a hospital manager and a doctor involved in the case came to this lady asking her to give her support to an article they wanted to put in the media stating how the hospital was a safe hospital in which to have a baby. She refused to do so. There had been another death of a baby there some weeks earlier. Let's focus now on RCSI Perdana and professional behaviour among students briefly. Look at this example here. A group of final year medical students are attending a busy clinic in an outpatient department of Clinic Kesihatan. Following the final teaching session on the Friday, David Lim asked the consultant to sign his assessment sheet. The consultant noticed that the box for cannulation and venipuncture had been ticked. He had specifically told the students on the Monday of that week, on their first day, they were not allowed to do any venipuncture during this week's posting. David Lim then returned to his colleagues who were next to go to the consultant to get their sheets signed and chopped, and advised them not to tick the box because he would scold them. Another student, Anissa, was overheard to say, "Don't worry, la, let him sign the form and just tick the box afterwards." Might be helpful to reflect on this and what you think this represents. Was what the doctor signed the same as what subsequently was uploaded as the signed assessment sheet? If not, what is the difference? What is the legal and ethical and professional way to describe this? Here's another one. You're in the intensive care unit at Hospital Kuala Lumpur at 7 a.m. The new day shift arrive for the handover. Jenny is a final medical student. This is her last day of her posting there. She's enjoyed it very much. She really got to know the staff and she learned a lot. Dr. Lee, the anaesthetist on duty today, arrives in and greets Jenny. She thought she could smell alcohol on his breath. Soon after, he let out a yawn and said, "Oh, I'm knackered. I had such a heavy night last night with my friends. We were in a club till 3 a.m. What are your feelings about this statement? And about Jenny smelling alcohol in his breath? What should Jenny do? What would you do about this? Is he fit to run an intensive care unit on a busy day in a busy hospital? Is he safe to take decisions about the care of patients who are often very unwell? And these may well be life or death decisions. Professionalism is one of many domains of good professional practice. Among the others are clearly having adequate clinical skills, being able to relate well to patients and to communicate with them and with your colleagues. Communication is such an important part of interaction with colleagues in terms of safety for patients, particularly at these transitions of care when people are referred into hospital or discharged from hospital, what is communicated is absolutely essential. The good professional doctor is also a good collaborator and team member. He's also good at management, both time management and self-care, that is healthcare, as well as managing his daily routine. He also keeps up to date, so he's scholarly. He's up to date with the most recent evidence for various treatments, etc. And all of these domains act in concert to provide safe patient care of good quality. So in this video, your learning outcomes should be that you should be able to identify areas of concern regards professionalism. You should be able to explain the role of various professional bodies and regulatory authorities. You should be able to define professionalism and identify the characteristics of a profession. You should be able to discuss professionalism in the context of the RCSI Perdana Code of Conduct and discuss the relevance of its teaching to you and its assessment in your undergraduate years. And finally, you should be able to describe the professional requirements for your future career. How to define professionalism? Well, there are several definitions. This one has stood the test of time. It's from 2002 by Epstein and Hundert. And it says, professionalism is the habitual and judicious use of communications, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of the individual and the community being served. That's a lengthy definition, and if you had to paraphrase this, it would certainly turn into several paragraphs. So it's worth dwelling on this for a while and reflect to yourself, what does habitual mean? What does judicious mean? And what about this dichotomy between the benefit of the individual and the benefit of the community? These are worth reflecting on, and we can discuss these in class. A profession is a group organized to develop competence in a specialized area of knowledge, be that law, medicine, engineering, whatever. And the professional group acknowledges that it has specific duties and responsibilities. It also has the autonomy to train, admit, monitor, and discipline its members. But the potential to develop a professional body is a privilege granted by society. It's not a right. What happens when professionalism breaks down? You have some examples here from the United Kingdom and from Ireland, where there were major breaches of professional behaviour by doctors. Let's look at these in turn. In Bristol Royal Infirmary, an inquiry was set up by the General Medical Council in 1998 to investigate the excess death rate among babies that undergone heart surgery. There are some concerns by health professionals working in the area, in particular one anaesthetist, about the excessive mortality rates in Bristol by contrast to other areas around the UK. The key outcomes of the Bristol Heart Inquiry was that 2 surgeons and the chief executive of the hospital trust were found guilty of serious professional misconduct. The 2 doctors were erased from the medical register, and the Dr. Dasmana registration was made subject to a condition valid for 3 years that he would retrain. Alder Hey is a large children's hospital in Liverpool, and the scandal here concerned the unauthorised removal, retention and disposal of human tissue, including children's organs. Professor Dick van Velzen ordered these unethical and illegal retentions of these children's organs, and he falsified records and post-mortem reports. He failed to catalogue organs, took away medical records when he left and moved to Holland. He kept organs in jars in his apartment and showed scant regard for the consents of parents. Reflect for a moment on this. These were parents whose children had died suddenly. Some had died of sudden infant death, others of different conditions. But these children had died, and some years later, when this inquiry was convened, these parents had to be contacted to explain to them that there would need to be exhumations because they believed that some of these children were buried without their internal organs intact. How traumatic is that? If you think of yourself now as a young parent who's had this experience, and then to be told some 7 years later that we'll have to exhume the body of your son and check if all his organs are intact. It's like he's died all over again. And this shows the depth of unconcern that this doctor had for these parents' feelings. In total, there were 105,000 organs retained. And that's probably a conservative estimate because Prof. Van Velsen escaped to Holland and did not return to the UK. There was also concern that the hospital and the university, for which he had an honorary academic appointment, failed to monitor his work or follow up on the complaints that were made. In Ireland, Lourdes Hospital in the northeast had a major scandal where Dr. Michael Neary, consultant obstetrician gynecologist, performed 129 peri-partum hysterectomies over a prolonged period. Now, the average consultant obstetrician is reckoned to carry out 5 or 6 in their entire career. These were mainly in young women, and the implication was they would never now be able to have children. There was a peer review by 3 consultant obstetricians who found no evidence of questionable judgment or faulty decision making. However, their judgment was faulty in that they allowed Mr. Neary to provide them with the case files of the cases he suggested they should look at. But there was separately an independent review by a UK Institute of Obstetrician and Gynecology consultants who identified lack of audit, lack of attendance at further training programs, a lack of clinical pathological conference attendances. Dr. Neary was subsequently removed from the medical register, and subsequently stricter competence insurance requirements have been imposed for all doctors in Ireland since 2007. What kind of complaints are made against doctors? What about Irish doctors? Excuse me. The main complaints are about professional standards, breaching Section 2 of the Medical Council's Guide to Professional Conduct and Ethics, acting unethically and unprofessionally. There are also a lesser volume of complaints about inadequate or inappropriate treatment, but failure to communicate or to be arrogant and rude, failure to supply medical records or reports to other doctors, to solicitors or insurance reports, and other complaints about doctors' fees. But this is the largest number of complaints about doctors in Ireland. In Malaysia, there were very few complaints. When you look at the total number of registered doctors, 4,400, this was in 2014. These are the total number of complaints, which only amount to 17. And the result, in most of them, was 6 were reprimanded, 2 were struck off, but the other 9, the charges were dismissed and they were found not guilty. There are some examples of the professionalism breaches from the Malaysian Medical Council 2014 publication. One where the doctor had a sexual relationship with the patient's daughter-in-law, and 2 others where there had been misrepresentation of background, degrees, and these people were not qualified to work independently as doctors. There are several others to do with medication, to do with safe keeping of many medicines, particularly potentially harmful or addictive medicines like psychotropic drugs or opioids. What about medical students? What areas of concern exist about that? Well, there's a lot of evidence now from disciplinary bodies and regulatory authorities that unprofessional behaviour in student years is significantly more likely to lead to unprofessional behaviour subsequently. And they reckon that attitudinal and behavioural problems start at undergraduate level. In a US case control study, it was clear that poor factual knowledge about the topics at hand, and not just to do with professionalism, but poor knowledge generally, was associated with the likelihood of unprofessional behaviour. And also there was attitudes of irresponsibility and also a sense of diminished attitude for self-improvement. These various regulatory authorities structure the range and depth of requirements for professional behaviour among medical students. The Irish Medical Council, and WIFME, the World Federation for Medical Education, and the General Medical Council, and also the Malaysian Medical Council. So, for example, non-attendance is associated with poor professional behaviour subsequently, failure to accept advice, disrespect for colleagues and seniors, breaching confidentiality, and poor communication skills. Plagiarism is a major problem and is often seen subculturally as okay. It's okay to copy because a colleague has done a good assignment, so he'll share it with me, that's okay. But by not attributing this, you are stating that this work is your own work, and it is not your own work. This is academic dishonesty and fraud. Aggressive behaviour, including bullying, and this is not just physical or verbal bullying, that too, but also bullying through social media, through Twitter and Facebook. So who are the regulatory authorities who monitor these behaviours among doctors and students? Well, the three we will be concerned with are the Irish Medical Council, the General Medical Council, and the Malaysian Medical Council. The Irish Medical Council has a duty to the general public to regulate doctors who practice medicine in Ireland, to protect them by promoting and ensuring high standards of professional conduct and professional education, training and competence. So it has a key responsibility to maintain the medical register, which is a register of all medical practitioners legally entitled to work in Ireland. It has a responsibility to ensure high standards of medical education and training, and in this they're involved in accrediting medical schools, for example, and setting standards for the maintenance of professional competence. The General Medical Council, similarly in the UK, is there to protect, promote and maintain the health and safety of the public by ensuring proper standards in the practice of medicine. And the law provides for four main functions under the Medical Act of 1983. The GMC must provide an up-to-date register of qualified doctors. They must foster good medical practice. They must promote high standards of medical education and training, and deal firmly and fairly when fitness to practice is in doubt. The Malaysian Medical Council similarly aims to ensure high standards of medical ethics, education and practice in the interest of patients, the general public and the profession through fair but effective administration of the Medical Act 1971. This is the structure of the Malaysian Medical Council. You can see it's quite cumbersome. You can look at this in your own time, but it's quite an organized structure. And they have, like the other medical councils do, an ethical code and guideline for doctors with a code of professional conduct, good medical practice, guidelines and confidentiality, and competency in practice, and so on. This is looking at the number of registrations. This was published in 2014. You see the level dipped here simply because internship was changed to 2 years, so that caused a little blip in the curve, but otherwise there's been a steady increase throughout. So the total number of full registrations is 3967, including the majority who are homegrown local graduates and a smaller percentage of foreign nationals. If the foreign doctors come from an unrecognised university or medical school, then they must sit and pass the medical qualifying examination to be eligible for registration. What happens to those who are brought before the Fitness to Practice Committee in Malaysia? The committee decides whether somebody is fit to practice based on medical or competence status and whether they need to be referred to the Medical Review Panel or MRP when deemed necessary. This Fitness to Practice declaration was adopted in 2013, and you can see here the outcome of Fitness to Practice. There were 34 cases in all in 2014, and you can see the outcomes here of those who were deemed unfit to practice and those deemed fit to practice. So when the Medical Review Panel reviewed those doctors who were suggested by the Fitness to Practice Committee, what did they recommend? Of the total of 339, 41 cases were deferred, 30 had their full registration ceased, 5 had their provisional registration ceased, and 21 needed further treatment. So the majority were deemed fit to practice, approximately 200. And these are examples we've seen earlier of the breaches of professionalism that have come before the Malaysian Medical Council. The Irish Medical Council similarly has a guide to professional conduct and ethics for registered medical practitioners. And again, it states explicitly that the relationship between the doctor and the patient is a privileged one, but it depends on trust. And the Medical Council attempts to safeguard the public by ensuring that the quality of the doctor's competence, behaviours and relationships is maintained. And they have specified particular areas where the doctor has to demonstrate maintenance of professional standards, for example, in areas of consent, confidentiality, end-of-life care, provision of information to the public, prescribing practices, and referral with an increased emphasis on patient safety. It also has influenced the expansion of guidance on adverse events and in open communication with patients, particularly after adverse events. They have produced a very fine video on professional conduct and ethics for medical practitioners, which you can view by clicking here. They've also produced a guide for medical students. And this is a guideline for medical schools on ethical standards and behaviour, which is appropriate for students. And this concentrates on these areas here: general behaviour, confidentiality, personal and professional interactions, dress and presentation, competence, health, medication, and drug and alcohol misuse. There's one difference between this guideline and a similar guideline in the UK with the General Medical Council, is that students are not subject to the Medical Council fitness to practice processes, whereas in the UK they are. And here is a quote from the General Medical Council on medical students' fitness to practice. This was adopted in 2005. And it encompasses the professional behaviour expected of medical students, the scope of student fitness to practice, the threshold of student fitness to practice, decision making, and the key elements in student fitness to practice arrangements. Effectively, in the UK, students can be deemed unfit to practice and their student undergraduate years cease at that point. The Malaysian Medical Council has no specific guidance or strictures, as the GMC does, on students, but states that the professionalism expected of registered practitioners would also be applied to medical students. In the RCSI Perdana curriculum, professionalism is seen as a vertical theme. It doesn't just begin when you start your clinical years or your clinical postings. And the medical graduate profile at RCSI Dublin and Bahrain and Perdana comprises 5 themes of biomedical science and research, clinical medicine, clinical competence, population and international health, and personal and professional development. And it's in this theme 5, that this is explored in more detail. So under the personal and professional development theme, the student should understand and respect the patient-doctor relationship, demonstrate the ability to work collaboratively in a team, recognize one's own strengths and weaknesses, and be open to assistance when offered, understand the legal and ethical responsibilities of a doctor, demonstrates personal, organizational, and time management skills, is committed to lifelong learning, self-appraisal and reflection, demonstrates information literacy skills, and understands the principles of healthcare management. And this is an outline of the policies and procedures in RCSI Dublin, Bahrain and Perdana, including regulations about attendance, policy documentation for professional behaviour, and procedural documents for both staff and students. Recently, the RCSI Perdana disciplinary procedure has been updated, and this is to ensure that students are aware that RCSI Perdana takes breaches of professional behaviour seriously. And increasingly, not just here at RCSI Perdana, but worldwide, lapses in professional behaviour are being met with increasingly stiff penalties, and sometimes leading to expulsion from medical schools. So the structure of our disciplinary procedure is now established as shown here. If a student exhibits unprofessional behaviour, that just can be lateness in arriving at classes, for example, you get a first stage verbal warning. This is then followed subsequently by a written warning and with advisory improvements required and the timescale in which they should be achieved. If there should be no further improvement following this first episode of unprofessional behaviour, or should there be a further separate episode, then a second stage warning is issued. These are no longer from here on verbal, these are all written. And again, a timescale for improvements is given with it. If there should be a third stage warning, then there's a significant risk that the consequence may be expulsion from the medical school. It will be quite difficult for a student, having been expelled from one medical school in Malaysia, to gain access to another. So how do we teach and assess your professional behaviour? Well, we set expectations of you, and this is done during the orientation sessions. So before your clinical postings start, you have a session with all the leads of the different specialties, outlining not just the course and the rotation, etc., but specifically what's expected of you in terms of professional behaviour. You also all have access to the various policies and procedures and codes of conduct that are available at RCSI Perdana. Faculty give you information about formal and hidden curricula, about role models and problem-based learning. So, for example, when you go out into your clinical postings, there are things that are done, there are procedures that are followed that are different from what you would expect given the formal training you'd have had as an undergraduate. This is the so-called hidden curriculum, or this is how things are done as opposed to how they should be done. And the dilemma often for a student is, what do I do here? Do I just do what they say? Because if I don't, they might give me a bad assessment at the end of the week, etc. So this is a definition of the hidden curriculum, but effectively it's what's done as opposed to what in theory should be done. The way things are done on a day-to-day basis. Even though it may flout all the rules you've been educated on, this is how the system works in a hospital, a clinic kesihatan, a GP clinic, or wherever. What about maintaining professional competence, assuming that you've managed to achieve a level of competence that is appropriate for your profession? In Ireland and in other countries now, professional competence schemes are established. In Ireland, it started in 2007 with the Publication of Medical Practitioners Act, which means that When this was finally brought into law, all doctors from 2011 are legally obliged to maintain the professional competence, and it is expected that on average each doctor will complete 50 hours of continuing professional development per year spread across the following areas. An internal session where maintenance of knowledge and skills is promoted, an external one where there may be a practice evaluation and development, personal learning and research teaching categories, or audits, for example, within a GP practice or within a clinic. Just to summarize again, professionalism is but one of several domains of good professional practice, and all of these acting in concert promote improved patient safety and quality of care. These are some references for you. We're now at the end of this video. Thank you.